Hi, I'm Dr. Margreet Wibbeling, midwife specialist and your host of the Birth and Baby show, brought to you by Sister Lillian Center and Sensitive Midwifery. We empower moms and midwives to have the best birthing and parenting experience through natural, physiological and intuitive care, resulting in birth and baby advice you can trust.
Hey, Babani.
Hey, how are you?
I'm great and very excited to have you here.
Yes.
Welcome.
To be here.
Welcome in the studio. We've been wanting to talk on a podcast for a while because we do a lot of talking. We talk all things midwifery all the time when we're together.
Yes, 100%.
Yeah. And I know Mbali has got lots to share with the world of midwives out there. So this podcast, we really are going to be addressing our colleagues. So just bear with us if you are a mother listening, because this all will benefit you as well. But we know we've got a lot of midwives and birth workers listening, so we're going to give it to all. But Mbali, I know you as a young, dynamic powerhouse woman. Tell the audience and listeners a bit more about yourself.
So I am Bali Pumalele Shabalala. Bali means flower. Pumalele means successful. One of my mom's favorite names, of course. I am a 28-year-old midwife. I'm a professional nurse and midwife. In South Africa, we study midwifery as well as being a professional nurse at the same time. But I'm very passionate about midwifery. I am an auntie of two little beautiful nephew boys. And I'm very passionate about midwifery.
So Mbali, have you always been passionate about midwifery?
Actually, yes. Midwifery has been something that has been embedded in me, but the word midwifery means with women. It wasn't always just about birth. It was always about being as present as possible with women. I went to a Catholic school, all-girls school, so I've been surrounded by women since I was 8. And looking back now, I was like, oh, shame, we're all going through all the hormones and the cycles at the same time. But
We do.
yeah, we do. And at around the age of 16, I recall it was my confirmation and I had chosen Christ. And it was time for us to decide which careers we're going to get into at the subjects we had to choose. And I knew I needed to do biology and mathematics because I wanted to get into nursing. And my mom and her friends who are in the profession as midwives, most of them are midwives, were extremely supportive towards me. But my dad was so against it. He was just like, no, you won't be able to live the life that we provided for you. Nurses don't get paid that much in South Africa. And I didn't care about how much I was going to get from the situation in terms of money, but I knew that deep inside that I had something to change in the field. And the first ward I ever worked in as a student was actually a gynae ward. So there were still midwives, but we did gynae-related cases such as your cervical cancers. We had the hysterectomies. So it wasn't necessarily pregnant just as yet. So I've been with women for a long time, but the second I got into maternity, I was home. I was seeing exactly that I was supposed to be there. But the journey hasn't been easy. You know, I actually remember speaking at the symposium and my topic was moving despite the odds. And it was a true reflection of what I was going through. I was moving despite the crazy odds that were coming up. But midwifery has always chosen me and I've always chosen it as well.
Amazing. So you answered to the call. I think many midwives can identify with that because it is really a call.
Yes.
And it will find you if much as often you want to run away from it.
Yes.
But tell us a little bit about the difficulties you've experienced in this journey. As you said, you've been moving against the odds.
Yeah, the odds. In my third year, so for some reason, I wouldn't say I was like an A student or anything like that, but I've never been a child that got less than and I was always an average student or just a little bit above average. And when I got to university, I think our curriculum was very different to how the diploma works. We worked and studied at the same time. Like you would literally lay your body in the morning and then lunchtime you go back to class. Like you just had to your brain had to switch automatically. But God had a way of keeping me in the course for as long as he needed me to. And I remember speaking to one of my mentors at the time, and she said, maybe your purpose is to give someone water, or to hold someone's hand as they give birth, or, you still have a bigger purpose over what you think you need. And I had failed the third year. Funny enough, I actually had to write a stuff for midwifery, which it took me off guard, but I think I had to go back another year, because in my repeating year, I worked in an MOU, it was Hillbrow MOU, as well as the high-risk clinic at Charlotte McDucker, which is an academic hospital. So we dealt with every condition you can think of and complication in pregnancy at its highest level and form. Unfortunately, I did witness a few maternal losses, but it was just a reflection of where midwifery can go if we're not managing it properly.
Sure.
So as a student, I spent a long time compared to my peers. I was there for 3 years. And in the government sector, if you work for more than 40 hours, you're practically permanent staff. Like, if it's a low-risk delivery, you can't be calling another midwife. They'd say, I'm still busy with this delivery. You continue there. If there's really, truly something wrong, then you call me. And I learned, so they were able to triage the clients in a way that I was just taking care of the low risk, or I'd be progressing most of the moms. So I was already starting to practice sensitive midwifery, but it was very, very medicalized at the time. Because of just how we were being taught, we were still performing the episiotomies, putting up drips when we're transferring a mom from the admission to maternity. They just have to always go with the drip, and looking back, it's like, we didn't need all of those things.
Right.
And then I got into my final year, I did very well, and towards the end of the year, I was like set on a plan that I'm going to move to Joburg, and because that's where I'm from, and I'm going to stay with my brother, and, I had my ducks set in a row, and the odds came up, and they placed me in a rural sector in KZN. And I remember walking into the office, and the rules of the hospital is that a conserve has to rotate. And I told the matron, I'm not rotating. I want to stay in maternity. And luckily, I was speaking to the matron who runs the maternity aspects of everything and theatre. So she was very happy to hear a young person wanting to stay in maternity.
Sure.
By the time the third month came into the year, that's when COVID came up, and I couldn't see my family, but I was just so focused on ensuring that I'm learning and being the midwife that I'm meant to be. And the midwives there still believed in the normal physiology of birth. Yes, it was still quite medicalized, but we didn't have the resources to be medicalized. So we wouldn't just misuse the drips. You had to literally be the most dehydrated person for us to use the drip. It wasn't just a routine. There was no routine care, if I could say that. Mm-hmm. Everything was kind of, we would assess your condition, and then we would place, there was even different places where you would be placed. So if you were low risk and non-problematic, there was a place where you'd be, and then the high risk moms would be closer to the nursing station. So everyone was managed accordingly, and our doctor hated doing Caesars. You gotta say, the Caesar's easy for me to do. I could just open everyone up, but they weren't healed the right way. It won't help them mentally. So he was very passionate about that. He actually chose not to specialize, because he knew if he specialized, he would bring that medical system into the field. And everyone there's still quite cultural. So going for a Caesar is like, it's the worst thing that could ever happen. Like the moms, the maternal mothers would cry actually if they found out that their daughters went for a Caesar. If you delivered naturally, it was like the most beautiful thing. There was no nursery, sorry.
No, carry on.
There was no nursery for like breastfeeding. The moms stayed with their babies from birth, because we didn't have cribs to put these babies in. So the babies stayed on their mom. We did skin to skin. So sometimes not having the resources aids us in being the best midwives possible.
Amazing. But you probably weren't, looking back, you can see the massive difference. But at the time, you were just discovering a lot of things in your midwifery journey, coming from a very highly medicalized environment where you were almost saying, you can see how things can get to the worst of the worst if you lose midwifery. and then coming to here, always restoring your or opening your eyes for true midwifery and realizing a few things.
Yeah, at the academic hospital, because I think in the urban areas, people know they can just refer. So they don't actually manage the situation properly. Like we'd have moms coming in who are pre-eclamptic, or they'd arrive to us eclamptic and deceased. But if you look at the records, you would see that the midwives at that point and the doctors at that district hospital could have managed it, like just stabilizing the patient. At Gaza, we didn't have a single maternal death. So it was generally like a different, it was a breath of fresh air. And like I could actually manage pre-eclampsia and nothing happens to the mom. She comes back perfectly fine. Her baby gets delivered. The baby's fine, you know. And Dr. Jonas always used to say that if you have a complication, especially when it comes to blood pressure, it's always the placenta. So as midwives, we already knew that, okay, if we're getting to a place, we need to try to stabilize her and get her to theatre. But if it's a low risk, he doesn't get involved. It's all us. Yeah, and we would manage that so well.
So that was a massive, amazing foundation that you got to become this midwife you are today.
Yes.
Wow. And from there, then you finish your studies?
So, I finished my studies. That was my community service. And then because the government had no funds, either at Gauteng Health and KZN, I couldn't find work. And my partner knows a lot of females, because there's a lot of female friends who were moms to little ones. And they got connections to do that. And I ended up working at a birthing center, which is in KZN, and very beautiful facility. And I think I was toning down from a very highly medicalized, and it was the rural sector. And then at the birthing center, I could actually be myself. And when I came across the Sensitive Midwifery course, this is everything I've ever wanted to do. This is everything, everything that was being said was like an aha moment. Because you could feel that I shouldn't be cutting her. Like when you're doing an episiotomy, you know, when I was in the hospital setting, like you knew that it wasn't right, but it felt like it was a life-saving procedure. The birthing center didn't cut a single episiotomy. You know, I guess because there was also less clients. But in the same breath, looking now that I'm back in the hospital setting, it doesn't matter how many people are there. Actually, just let her stand up and walk around until the head is actually nice and low, to know. And also the perineum can slowly get stretched. And these are the things that you learn in the Sensitive Midwifery course. And unfortunately, I did cut a lot, but then in the birthing center, we were able to just manage the pregnancy very well. That's also another thing that I loved about the birthing center, is that it was a holistic care. It's from 6 weeks or 8 weeks pregnancy all the way to 6 weeks postpartum. So I could walk the journey with the mom. I could tell her, no, this is what's going to work. This is not going to work. Just rather eat this. Don't eat it at 34 weeks or 36 weeks. You should start trying to cut down sugar because it helps with the bleeding. And by building that relationship, moms were able to trust what was going on. Because I think, especially for first-time moms, pregnancy is a huge transition. They don't even know what's happening to their bodies. The hormonal levels are just skyrocketing. So they're practically also like children learning about something completely new. So as the pregnancies go, of course, they get a bit better, but I still treat even a fifth-time mom as a first-time mom, because it's a fifth-time being pregnant. It's beautiful as a first-time mom.
Yeah.
And at the center, we could actually implement the course, but in the same breath, it's not the only place where you can implement the course.
Yeah.
Being a sensitive midwife is not about necessarily where you are. It's about what you're doing. So if you have good intentions that you know this is for the betterment of the mom's health and the baby's health, you're less likely to intervene in a way that is unsafe.
Yeah. Exactly. Absolutely. I love that. So, Bali, what a story. So what of all the things that you've learned and observed and who you've become, what is your dream? What do you think, what do you dream for midwifery in South Africa?
Yeah, so I felt that with what's happening, like in the government sector, there is a bit of support between the midwives and the doctors. There's a bit of a relationship that goes on there. I think also that maybe because the doctors themselves are very supported, because it's professors who have been in the game for a very long time and know the power of midwives. versus, for example, in the private sector, there aren't a lot of specialists like professors and people who have worked closely with midwives in a way where midwives do the deliveries. So I also enjoyed the independent work. So I experienced all the different aspects of everything, and my passion more than anything is to bring back midwives in the obstetric table. Like, our voice needs to be heard, because at the end of the day, the word does mean with women, and we will always fight for women's rights. Doctors, the way they train, and I'm so grateful that I trained at FITS, because I trained alongside with the doctors. They're only trained to do low risk. I think it's like they have to observe about 10 births, and that's it. After that, they go into the high risk sector. And we do need people who have those goggles. We can't both all think that everything is airy-fairy and low risk. Yes, we need to know what is right, but they need to be able to detect what's wrong. So I would like to be in a place where midwives can be trusted in the private sector, especially because in the government sector, I feel we are trusted, and we need to kind of stand up and be more assertive, because a lot of midwives just end up just getting into a routine in the government. As I was saying, you just get into a medical model and you just do things because other people are doing things. But in the private sector, there is more of a voice, because there's an independence that you can get. You can open up a birthing center. You can have antenatal classes. You can be a lactation clinic. There's a lot of things that you can be, which can empower women, but we're not supported by the doctors. And the reasons why we're not supported by doctors is because of the things that they're hearing. But we need to show them how it actually works. They'll hear one bad story and they switch off, which is normal for any human being. But we need to kind of also work according to that. So if you do the sensitive midwifery course, it aids you to be guided to work in a safe space. And when I was at the birthing center, I didn't have an issue where I had a doctor saying, we'll never work with you again, because I would have rather referred earlier than later. We would go with the client into the hospital setting and do a proper handover, state all the things that we've done, so that the care is kind of transitions and the doctor's comfortable and the midwives in the hospital setting are comfortable. I'm enrolled in a public health diploma with the University of Pretoria, where I'm going to be learning about policy development, because the change, before we can change the law, we need to kind of make the change between ourselves. Creating small policies, like if all our midwives were standardized, that we all certified to practice, and doctors can trust our certification, then it will be easier for them to also work with us. But currently, we're quite divided. The midwives that I've encountered, the private midwives that I've encountered, have done the course, but we need more midwives to do the course, not just independent midwives. We need the midwives also in the hospital setting to do the course, so that when you do transfer someone in, they understand why you had cared for the client that way, why you did not intervene.
Yes.
Because it's not that it's not our space to intervene, but the second you start with the interventions, it's a cascade.
Exactly.
So you'd rather, of course, be in a safe space where you could do those interventions. But as I'm saying, I think the type of transfers that I did at the birthing center was because Mom was mentally not coping with the pain, and that's something that she would have had to not deal with per se, but it's something, if she can't, you can't force her. So if she said she wanted to go to the hospital, I'd never say, no, you'll be fine. No, we still respect your wishes, and we're going to the hospital setting. But other than that, like most of the moms, because we had monitored you so closely, if before 36 weeks we could see that we wouldn't be able to do it, of course we'd have really transferred you to the doctor by that time. So there are safe practices in place. It's not that we are just,
Yeah, it depends which setting you're working. So for every setting, there's some certain policies in place and rules of the game. So as an independent midwife, it's not that you can't do all these interventions. You might be an advanced midwife even, and you're allowed to, but it's not conducive for the environment you're in. That needs to be done in a hospital environment where you have access to all the medical team. So it's about a mom and baby safety. So it's just understanding midwifery clearly. It's and I think that is where midwives, as you say, need to get more understanding, that they understand each other, because we are divided in understanding of midwifery. Right?
So it's really painful actually to see, because I don't know if you've ever witnessed this, in the government sector, if a doctor does something wrong, right, they will have his back or her back. Like the professor will be there, everyone will just be there to be for that person. But the second a midwife does something wrong, everyone just steps back, and it's her problem or his problem, you know. And I found that we were at Rahima Musa actually, because we were doing that mentorship program.
Yes.
And there was one midwife, unfortunately she had lost the baby because there was a long waiting time in theatre, but she had already reported it to the doctor. So for me, in that incident, everyone should have been part of it, like calling, because she had 6 other people to take care of. So it's not her issue alone. Even when an independent midwife from the outside transfers a patient into the hospital setting, she's transferring a community member into the facility. So whether that person had started labor on their own and came, you still need to treat them the same, because some clients, and I learned this in the raw sector, they'll take their own forms of inductions. They'll do their own things at home. But rather her be with a midwife, an independent midwife, until it's time, if she ever needs transfer, because it's safer that way.
Yeah.
But we're just so quick to have each other's backs. Even in the independent midwifery world, like if someone does something wrong, it's like the entire independent midwifery now has to kind of like cancelled. And that's not how it is. Even if one person does something wrong, it's not a reflection on all of us.
Correct.
But if we're not all united from the get-go, it's very easy for us to get singled out.
Yeah.
Because we're not painting the same brush.
Yeah.
Yeah.
So I cannot agree with you more. It's very, very much a big passion of me. What we stand for is that we need to unite. Yeah. And those are sounds I actually hear internationally. Like the theme of the year for Sensitive Midwifery and the symposium is Better Together. Yes. And I just saw actually recently the ICM also have that theme. It's also Better Together again, and putting back evidence into practice. And that's all about, so it's like a global thing that needs to happen. And that's what South Africa really for our midwives is that we want to unite, we want to engage with one another across different sectors, that we understand each other and we become a sisterhood and a pack instead of, you know, as you said, you're on your own if something happens.
Yes, we're supposed to kind of like bring that person in and actually protect them within our, and find ways of actually managing the issue, because anyone can make a mistake.
Yes.
I don't think anyone wakes up in the morning and says, you know what, I'm going to hurt all these people.
Never.
No one does that.
And no one becomes a midwife to be a terrible midwife in the end.
No one. Yes, no one. And even if the actions of that midwife were really, really horrible, it's never the intention to actually harm them. Most of the time, they think it's actually the betterment of the midwife. And anyone can take it too far. And even doctors, you'll find people doing Caesars for big baby, and the baby comes out at 2.5. You know,
well, that's a very much misjudged one. But
then that doctor won't be ridiculed as much as if a midwife had to do something like that.
Yeah,
you know. So attending something like this symposium could create unity, because we don't have any other platforms currently. We have the course, we have the Sister Union Center, and that's what we should be using. I didn't know about sensitive midwifery, but I wish I knew about it even as a student. I was lucky enough to have a lecturer who was a wombs lecturer, so she trained doulas, but it wasn't the same as when I was actually now implementing the sensitive midwifery course. And it's not a birthing, as I keep saying, it's not an independent midwife course. It is also for the hospital midwives.
Absolutely.
Because even with that, I've said this so many times. I told you the stories where I wouldn't be allowed to monitor the moms in the hospital setting, because they always deliver before the doctor gets there. So I want to be contracting the whole week, and the doctor says, no, she's for discharge tomorrow, and they assign her to me, and I'm like, hey, let's go to the nice walk around, eat, drink, and I'm, like just encouraging her to relax, and she ends up feeling like she needs to push. Always getting into trouble and having
I think it's your magic, but it's not rocket science.
It really isn't. And to write statements for during delivery, so I just kind of stayed on the other side.
Okay, Mbani, give it your best shot to call for our midwives to come to the symposium, to unite, to stand up for our profession.
100%. I truly believe that it doesn't matter where you are. As I said, I've worked in the worst environment and one of a 5-star environment, and both required me. They require the best of me in every way. I've tried to not allow the storm around to always affect what's going on with it. And you still need to be a very vigilant, problem-solving midwife, and to think for not just for the betterment of your own good, but just for midwifery as a whole. And attending a symposium is so crucial, as you get to meet other midwives. You see that you're not alone in this world. And if you are looking to start up, and if you are stuck in the hospital setting, yes, for some of us, we have children and commitments, but leave the space, because that's what actually makes you not want to be a midwife. When you go to the symposium, you'll meet people like me, where I resigned from a work because I really had a passion for midwifery. I wanted to showcase how midwifery is actually such a beautiful profession, that we can work with doctors closely, and doctors can trust us, and we should trust them. And most importantly, that we should trust each other. So let's work together in building a friendship and a relationship in midwifery, and just for the betterment of our women.
Absolutely. And that's what we're all doing it for. It's for better birthing outcomes, for happier families, happier societies. We are so important. So I hope you're encouraged by Mbali's amazing story. And she's young, still lots gonna happen through this beautiful woman. So be inspired, take up your midwifery badge, go run with it. And together we can. Better together.
Yes.
So we'll see you on Symposium in May.
Yes.
Also, thank you so much, Mbali.
Thank you so much for joining us today. If you enjoyed this video, please share this with a friend who will benefit from this. And remember to subscribe and hit the bell icon so that you can be notified whenever we release new videos like this on our channel. We'd love to stay in touch and keep you updated with all our latest content and resources to equip and empower you. So if you're a midwife or any type of birth and baby worker, go to sensitivemidwifery.co.za/free gift. If you're a mom, visit sisterlillian.co.za/free gift for more training and resources. That way we can keep you up to date when we release new episodes like this, plus a few other bonuses. You can also find the links I just mentioned in the show notes. Remember, you're making a big difference because you are shaping the future of humankind. Thanks for watching, and I look forward to journeying with you.